All right. So it is 6:03. It is the start of lecture number 4. Thank you. And again, running just a little bit late, giving people some time to get on, but we have a massive amount of content to get to. So it looks like most everybody has got their homework from the last session in. And very good job, everybody. I got a little slack for the week before just hitting the like button and not putting out some good comments. So kudos to everyone. So let's get started. If you have questions, feel free to throw them in there. I'll apologize for how the audio may come across. The recorded session that I'll put online in the next couple of days will have all of the original audio and video cut into it so that it's better. So anyway, let's get rolling here. So here we're going to deal with the forearm and the leg. Again, this is just introductory information. The rest of it we will have a lot more detail. Matter of fact, I started working on compiling all of the advanced information into this online format today. So should be good to go there. Let me move that out of the way. Okay, so what we'll look at today is now this looks like a long list, and it is, but in the forearm flexor and forearm extensor, we're going to have a single, on this introductory, we're going to have a single dry needle for the forearm flexor group and for the forearm extensor group. We'll touch briefly on the three-dimensional anatomy of these structures, but where we really want to focus today is on that common, which is always the first treatment approach, needling through the muscles in bulk. We'll then move up to the upper leg and the posterior thigh. We'll look at needling of semitendinosus, membranosus, the biceps femoris, and adductor magnus. We'll go to the intralateral thigh. Here we'll go after sartorius, and then all four muscles of the quad into the lower leg. Intralateral, Tib Anterior, Extensor Digitorum longus, Extensor Hallucis longus, and then the peroneals. Then we'll move to the superficial posterior lower leg, Gastroc, Soleus, Plantaris. And then the deep posterior leg, where we get to Popliteal, Flexor Digitorum longus, Flexor Hallucis longus, Tib posterior, and then we'll hit 4 of the main ligaments that we see in the lower body. Clinically, the patellar tendon or the patellar ligament, the lateral collateral, medial collateral, and then down in the ankle foot, we'll needle the Achilles, and then up a little higher at the musculotendinous junction. At the end of the lecture, obviously, we will have a post-lecture assignment. This one will be more of a thinking assignment where I haven't given you the answer. It's just going to be a little bit of some thinking on your part. So a couple of pieces of supporting evidence. Just went and did some search for a couple of pertinent things. And this one by Uger from, where's it from? This year, January of this year. And they looked at the use of dry needling versus corticosteroid injection to treat lateral epicondylitis. They had 108 patients. Pain wasn't relieved by 3 weeks of first line treatment. And they were included. Minimum follow-up duration was 6 months. At the results, 7 patients were excluded, so 101 patients were evaluated. The groups were similar in age in terms of age, symptom duration, and PRTE score, but after treatment, dry needling treated patients showed better improvement in the PRTE score than the corticosteroid treated patients. So the conclusion, the dry needling and corticosteroid injection both afforded significant improvements during the 6 months of follow-up. However, compared with corticosteroid injection, dry needling was more effective. We look at a second piece, Caballos Leda. This is from 2019, effects of dry needling in the hip muscles in patients with hip osteoarthritis. Their patients' treatment was into the iliopsoas, the rect fem, TFL, and gluteus minimus. I would have selected some different treatment points clinically myself, but this is what they did. They also looked at pain intensity, passive hip range of motion, physical function, both at baseline and then after 3 treatment sessions. The results decreased in pain intensity, increased hip range, improved physical function following the dry needling treatment. And they were statistically significant compared to the sham group. So conclusion was pain, hip range, physical function improved after the application of DN and an active, of course they use motor trigger points, of the hip muscles in patients with hip OA. So a couple of studies supporting the use of dry needling in some fairly common clinical things that we see. On clinical decision making, I'm going to vary a little bit from what I've done in the last 3 lectures. Here I want to talk about how to identify which muscles are demonstrating the neuromuscular dysfunction. We want to first determine the orientation of the muscle fibers, then we want to palpate across the muscle fibers to find the ropey muscles, and then we want to palpate along, not along, but along the muscle fibers to locate the focal points of dysfunction. That brings us to the first video of the day. So a little on clinical decision making. What we want to talk about is how to identify which muscles are involved, which are experiencing any sort of neuromuscular dysfunction. Those are the tissues that we want to end up dry needling. And so as we get later, as you get more experience going through the treatment protocols, you will find that you go target these specific areas first. But for now, I just want you to focus on the exact finger breadths that we're identifying in the labs. So one thing we want to do, we know that patient comes in complaining of pain in the lateral arm, tennis elbow type symptoms. So obviously one thing we want to do is find out, what is the exact muscle. That'll tell us where we want to needle. And so one thing we want to do first is be aware of the orientation of the muscle fibers. Here in the wrist extensors, fairly straightforward. Obviously the muscle fibers are going to run from proximal to distal. Other muscles, say in the deltoid, important to understand how that muscle comes across from its point of origin over to its attachment. So first thing we want to do, identify that direction of the muscle fiber. Second thing we want to do is in each muscle, so we'll go through our manual test to find out, especially this group, which muscle we're dealing with. So again, second thing we want to do is we want to palpate across that muscle fiber. Here we're looking for which structures, which muscles have that ropey sensation in there. You do that, you should feel almost a rope or a pencil laying underneath that tissue. And so that'll help you identify which muscle you want to target. Thirdly, what you want to do is then palpate down the length of that muscle fiber. And very frequently in that, you'll find the focal point of pain. And so it's just a process to help you go through and actually find out where the real problem is. In our case, even if we've got the focal point here, and we identify, okay, that's extensor carpi or extensor digitorum, we still then want to go through our procedure to identify and needle that in that place. Later, as you get more proficient, then you may find that you vary a little bit from that to actually go down to that point of tenderness. So again, just an easy way to identify which muscle we're dealing with by first identifying the orientation of the muscle fibers themselves. Secondly, strumming across, if you will, that muscle to identify if it seems to have some tightness going on. And then thirdly, to palpate down to identify any specific focal points of tenderness. Okay, so we've already talked about what we're going to do here. So let's just move straight into this. We'll start in the forearm. Here we'll look at, again, we're going to do this as a single unit for purposes of this introductory piece. And honestly, clinically, that is usually very effective. Probably 75% of the time, just doing this needle for your tennis elbow or golfer's elbow is all that's required. It's when it lingers and it takes more than a couple of sticks that you have to then break out the remainder of this musculature. And so in this picture, you can see, so we talked about the common flexor or the common extensor or flexor group, but we also, again, this will be in a later course, can needle into the common flexor tendon and at the tenoosseous junction. Again, if that single stick doesn't do that runs across the bulk of the muscle, you can get into the tendon itself if there's some active tendonitis going on or some dysfunction there at the tenoosseous junction or the myotendinous junction for that matter. So we'll look at Pronator Teres, and I'm gonna move from here straight into this. Will be in the online portion for you to look at, but let's move into the 3D anatomy piece where we discuss this a little bit more detail. So skipping. Okay, so the 3D anatomy here, the common wrist flexor group at the elbow. This is going to be the structures on the medial aspect. Let's start with the more superficial muscle group. As I move this around, this is going to be all of the structures that we see along that medial ridge that goes from almost midline of the cubital fossa that we can palpate and test for, going all the way laterally down to the olecranon. So first one, get that back over here, Pronator Teres. So it's, and let me pull that information up. So as you see, its origin, the medial supracondylar ridge of the humerus, and also via the common flexor tendon, and also on the medial aspect of the coronoid process of the ulna. So it's got a diverse, let me fade those others. So both origin off of the ulna and the humerus and this bifurcated muscle itself. We look back at it. Let me bring those others back in. It's insertion, the middle 1/3 of the anterolateral aspect of the radius. So here we are in the anatomical position. The proximal 1/3, it says the middle 1/3. I would call it closer to the proximal. Anyway, its action is it pronates the forearm at the radial ulnar joints. The next muscle in line, so that muscle gets really important whenever we get to the dry needling. We're going to needle that medial and the lateral group based on some anatomical structures that we have. On the medial aspect, being able to identify Pronator Teres is definitely our landmark for needling, say, golfer's elbow through this bulk of muscle. So we'll move on to, let me reduce that. The next one in the row is going to be flexor carpi radialis. Highlight that. And so as you can tell, it's got again, a proximal origin there on the medial epicondyle of the humerus, again, via the common flexor tendon. So this one now we're going to be seeing all of the remainder of these muscles. It shows them being very distinct, but it's generally referred to as being a single common tendinous structure across all of those. It inserts the palmar aspects of the bases of the second and third metacarpal bones, so very far distally. You see that in yellow there. So flexor carpi radialis crosses the carpal rows themselves. And then its action is it flexes the hand at the radiocarpal or the wrist joint, and it abducts the hand at the radiocarpal and midcarpal joints. Its innervation is the median nerve. We move from there. Let's see if there we go. The next in the row is going to be the palmaris longus. So Pronator Teres, flexor carpi radialis, and then palmaris longus. For that muscle, again, that would be, as you see down at the wrist, if you resist wrist flexion, that's going to be that tendon that pops up right in the carpal row. Its origin, the medial epicondyle at the humerus, again via the common flexor tendon, and inserts into the palmar aponeurosis and the flexor retinaculum of the hand.
And so again, that's what we're going to see pulling up your resist wrist flexion. It's going to put some tension on that palmar aponeurosis. Innervation in median nerves 7 and 8. We move lastly to the flexor carpi ulnaris. Get that highlighted. Perfect. Here, the origin again, the medial epicondyle of the humerus via the common flexor tendon, and then the proximal two-thirds of the body of the ulna and the olecranon of the ulna. So this, whenever we do start to talk about our specific protocols when treating for ulnar nerve entrapment, we can actually come in. This flexor carpi ulnaris very important for treatment of ulnar nerve entrapment, and we can really do a good job of needling there, and we get a little bit more specific down into the ulnar collateral ligament, and there's another that we'll talk about when we get to that. But those are the four more superficial medial muscles that we deal with when we're needling there. So let's also now go take a look at the deep musculature. I'm going to switch. Where did I go? Here I went. So for the deep musculature, here we're going to look at flexor digitorum superficialis, profundus, and then flexor pollicis longus, and then the pronator quadratus. Flexor digitorum superficialis, close that there. All right, I've got it hidden or faded at the moment, but let's pull that up. Its origin, the medial epicondyle of the humerus, again via the common flexor tendon, and the sublime tubercle of the ulna, and the proximal half of the anterior border of the radius. So really large footprint as far as its origin. It inserts into the palmar aspects of the bodies the middle phalanges of the index, middle, ring, and the little fingers. And again, actions here as it flexes those same digits 2 through 5. Innervation is C7 through T1 via the median nerve. We go a little bit deeper and look at flexor digitorum profundus. Bring that back around and zoom back in. And so profundus sits deep to the superficialis. Origin, the medial aspect of the coronoid process of the ulna, the superior 3/4 of the anterior medial surface of the body of the ulna. It inserts into the palmar aspects of the bases of the distal phalanges of the index, middle ring, and little fingers, and their action is flexing, again, digits 2 through 5. Here again, innervation, the medial part, curious thing, medial part is of the ulnar nerve, C8 to T1, and the lateral part is the anterior interosseous branch of the median nerve, C8 to T1. So one of the few times we have a single muscle innervated by different nerves. So ulnar and median nerve innervation. We get to the flexor pollicis longus. We highlight that. So we see here its origin is the anterior surface of the radius in the adjacent interosseous membrane of the forearm, with the insertion into the palmar aspect of the base of the distal phalanx of the thumb. And so we know we cover a lot of territory here. Let me come in, and I want to hide that that sheath so that you can really see the distance there. So flexor pollicis longus. We go finally to pronator quadratus. Here, our origin is the anterior aspect of the distal 1/4 of the ulna, and it inserts into the anterior aspect of the distal 1/4 of the radius, and its action is pronating the forearm at the radial ulnar joint. Innervation here is anterior antebrachial interosseous nerve, C7, C8.
Okay, so with that medial group, whether we're dealing with tennis, or I'm sorry, golfer's elbow, or whatever we're considering. Let me get that back up. Good. it could be for pain, it can be overuse. Frequently can be used with, say, spasticity from some sort of a neural incident, say with CVA, stroke, etc., for reducing spasticity. So, depending on what we're seeing going on, a lot of potential for reducing that neuromuscular problem that we're dealing with. So, the surface anatomy lab. When we get to the advanced course, all of this is going to be very pertinent for what we're dealing with right now. I'm going to leave this for your review. We will get back to the meat of all of this several lectures from now. But let's get into where we are most interested. And actually, it's going to be that one right there. So let me get to this. So in dry needling, the common wrist flexor and extensor, we want to look at some specific surface anatomy. First thing we want to do is identify our cubital crease. Very simply, we're going to come across that location right there. Then what we want to do is find our cubital triangle here. We talked about the danger zones. We want to stay out of this area as much as possible. And so first what we'll do, this triangle is bordered by brachioradialis and then Pronator Teres. So first off, we'll identify brachioradialis. You're going to have your subject hold and resist flexion. As you do that, you can identify the medialmost border of brachioradialis. So as we're doing that, go ahead and relax. Kick them up again. Very good, and relax. That'll help me identify this border. And then what we want to do is come in to identify the medialmost border. Is we're going to just place our finger in that cubital window and we're going to resist pronation. So if you will, roll your hand down. And that will give us that border there. So from there, I'll mark there. So this is our danger zone. We want to stay away from here. When we do get to dry needling, the extensor group will be lateral to this spot, and on the medial group will be medial. So for the flexor group in treatment, we'll find that medial and lateral treatment is very similar, becomes quite simple and basic, quite honestly. As you can see, I've marked on brachioradialis the location where we'll needle. You can see right here where we had marked those areas. And if I remember right, you had a piece of homework that was specific to this. We just identified the crease and then came down. But let's get into the treatment. And matter of fact, I mean, we've got it here, but I've got the video that has all of this information. The biggest thing is we're going to needle 1 thumb breadth distal to the biceps insertion. We're going to advance it into an anterior to posteromedial direction away from midline at about a 45-degree angulation. And we'll use our fingers on that backside to determine proper depth. We want to make sure we get through the bulk of all of that tissue. At the elbow for the common flexor group, patient again is going to be in the supine position. Needle length here will be 30 to 40 millimeters, and there is no backdrop. Our precautions are the basilic vein, the ulnar nerve, the posterior ulnar recurrent artery and vein. So in the supinated position, we're going to palpate for the bicipital insertion into the radius. We're going to grasp the muscle belly of the flexor group medially, and then 1 thumb breadth distal to the biceps, insert the needle and advance in an anterior to posteromedial direction away from midline at a 45-degree angulation using the fingers to determine adequate needle depth.
Okay.
Sorry, my graphic is in a little bit of the way there, but we just split Pronator Teres right there, move just a little lateral or about a thumb breadth distal from the bicipital insertion. And the needle orientation is away from midline at about a 45-degree angle. You can see my fingers on the backside providing a palpatory place for proper depth. Okay, so that's the common forearm flexor, or actually it's a common wrist flexor at the forearm. So let's move into the extensor. Very similar to what we just talked about for the flexor group in the extensor. Later, we are going to needle each and every one of these muscles individually. We'll go through the test to make sure we're identifying the right group, right muscle. Here, however, we're going to just go for that common extensor group to do our introductory needling. So I'm going to roll through a lot of the material here, which is here. We're going to cover it in 3D anatomy. So we'll come on, get there. All right.
Okay, so let's move into the lateral elbow muscle group. We'll look at the superficial muscles, and then we'll move into the deep musculature. Again, we're going to look at the muscles that follow in a very predictable line of attachment. They can be palpated and followed from proximal down to distal on the lateral aspect. So first muscle will come in brachioradialis. We've talked about this one before, but for our purposes, we'll look at it again. So brachioradialis, the origin is the superior 2/3 of the lateral supracondylar ridge of the humerus. It inserts into the lateral aspect of the distal part of the radius. So we come way down. And so its action is it flexes the forearm at the elbow joint. Since that's the only joint that it passes, that's its action. Its innervation by the radial nerve, C5, C6. Next muscle in line is going to be the extensor radialis longus. Here, our origin, let me rotate a little bit. Again, the inferior 1/3 of the lateral supracondylar ridge of the humerus. Our surface anatomy, our palpation, need to be able to identify that so that we can then differentiate these muscles, both brachioradialis and ECRL. It inserts in the dorsal aspect of the base of the second metacarpal bone. So we get closer in. So here we have brachioradialis. It's its insertion, and then come further. We see ECRL, the longest, attaches to the base of the second metacarpal bone. When we get to ECRL brevis, we'll see that it attaches to right here into the third. Right there. Okay, but back here. So here, our action extending the hand at the radiocarpal joint and abducting the hand at the radiocarpal and midcarpal joints. So that motion lets us identify with a little radial deviation, a little extension, resist those, let us identify those, that musculature itself. Okay, so innervation is the radial nerve, C6, C7. Again, we'll move up and look at extensor carpi radialis brevis. Here its origin is the lateral epicondyle of the humerus. So we're off of the lateral epicondylar ridge. Now we're actually on to the lateral epicondyle, and here's the start of the muscles that will form the common extensor tendon. Later, dealing with specific protocols, we'll talk about dry needling into that common extensor tendon. Again, the insertion is the dorsal aspect of the base of the third metacarpal. Its action, again, extending the hand at the radiocarpal joints or the wrist and abducting the hand at the radiocarpal and midcarpal joints. Innervation here is the deep branch of the radial nerve, C7, C8, and the posterior interbrachial interosseous nerve. Move further laterally. Now we're at the extensor digitorum. Again, its origin is the lateral epicondyle of the humerus via the common extensor tendon. It inserts into the dorsal aspects of the bases of both the middle and distal phalanges of the index, middle, ring, and little fingers. Its action is extending the second through the fifth digits, and it's innervated by the posterior antebrachial interosseous nerve C7 and C8. we finally move to our more lateral location, extensor carpi ulnaris. Again, origin is the lateral epicondyle of the humerus via the common extensor tendon and also the posterior border of the ulna. Can't really see that in this representation. It inserts in the medial aspect of the base of the fifth metacarpal bone. And its action is extending and adducting the hand at the wrist joint. It's innervated by the posterior antebrachial interosseous nerve C7 and C8. So let's move back to the library. Let's look at the deeper musculature here. There's our superficial, extensor deep. Okay. So here, let's close that screen. All right. So a lot easier to visualize these muscles without the superficial on, so I take those off first. We'll look at the supinator. So just a visual representation here. Let me get that all the way over. So the origin of the supinator is the lateral epicondyle of the humerus and the supinator crest and the supinator fossa of the ulna. So again, a bifurcated muscle with two different bony origins. Its insertion is the anterior, lateral, and posterior aspects of the proximal 1/3 of the radius. So strong, powerful mover there. Action, supinating the forearm at the radial ulnar joint, and its innervated posterior antebrachial interosseous nerve C6, C7. We'll move to the adductor pollicis. Abductor Pollicis longus. Get that highlighted, and we can see that its origin, the posterior aspect of the proximal half of the ulna, and then the middle 1/3 of the radius adjacent to the interosseous membrane of the forearm. Its insertion is the lateral aspect of the base of the first metacarpal bone. Get that turned all the way, and it's that unique origin and insertion that gives that muscle its ability to perform its action, which is abducting and extending the thumb at the first carpometacarpal joint. Again, innervation is C7, C8. We will move to the extensor pollicis longus. All right, and I've got it faded at the moment. Let me bring that there. So extensor pollicis longus, its origin, the posterior surface of the middle 1/3 of the ulna and the adjacent interosseous membrane of the forearm. Its insertion is the dorsal aspect of the base of the distal phalanx of the thumb, and its action is extending the thumb. So it and the adductor pollicis longus both play a role in extension of the thumb. Its innervation, C7, C8, the posterior antebrachial interosseous nerve. We then get to extensor pollicis brevis in between those two previous muscles. So extensor, actually let me fade that. Okay, so extensor pollicis brevis. The origin is the posterior surface of the distal half of the radius and the adjacent interosseous membrane of the forearm. It inserts in the dorsal aspect of the base of the proximal phalanx of the thumb, and again, it extends the thumb. Again, it's C7, C8. And then lastly, the extensor indices. Get that highlighted, which its origin on the posterior surface of distal 1/3 of the ulna and the interosseous membrane. It inserts into the extensor expansion of the index finger. So way out here. And it extends that index finger, and again, innervation is through the posterior antebrachial interosseous nerve, or C7, C8.
So again, a lot of this surface anatomy we'll get into in our later advanced course in the elbow. It'll be good to know whenever we get to those things. Right now, we've got some a little bit simpler anatomy to look at. And matter of fact, for this common extensor, sorry, I had a brain melt, extensor group, we've already done the surface anatomy when we drew everything for the medial. So we've got the brachioradialis is going to be our lateral border for this piece itself. So I'm going to skip through that for time's sake. And very similar to what we did on the medial group, here we are for the lateral, the extensor group. Same distance, same orientation, 45 degrees away from midline. Again, using the fingers to determine adequate needle depth. At the elbow, for the common extensor group, we're going to needle all of the muscles as one unit. Here, your needle length will be 30 to 40 millimeters. There's no backdrop. Precautions here also radial nerve, the radial collateral artery, the radial recurrent vein, cephalic vein, and the muscular branch of the radial nerve to the brachioradialis, and the accessory cephalic vein. So in a supinated position, we're going to palpate for the bicipital insertion into the radius. We're going to grasp the muscle belly of the extensor group, and then 1 finger breadth distal to the biceps insertion. We'll put the needle and advance in an anterior to posterolateral direction away from midline at a 45-degree angulation, using the fingers to determine adequate needle depth. So in that video right there, it appears that the needle is going completely anterior to posterior. It's probably not at a full 45 degree away from midline. However, we're far enough away from that cubital crease and the bicipital insertion that we can get away with that. The only problem with that angulation is that I'm probably going to miss out on some of the rest of the extensor group, ECRL, ECRB, extensor dig, possibly even further laterally. So the whole point behind that 45-degree angulation is to make sure that we thread through all of that musculature. So upper arm. Now let's move on to the upper leg. Okay. So here we're going to talk through the posterior thigh here, semitendinosus, membranosus, biceps femoris, and adductor magnus. I'm giving some very introductory ways to needle these muscles. As we get to the advanced hip and lower leg, we will find different ways to needle these muscles, but I want to give you some safe alternatives to make sure we can have a nice impact on all of these structures. So we'll bypass all of the description here. We're going to discuss this in our 3D anatomy. So let me move straight to that.
So let's look at the muscles of the posterior thigh. Here we're talking about semitendinosus, semimembranosus, biceps femoris, and the adductor magnus. First, the semitendinosus. Pull that up, get that highlighted. Okay, so its origin is off of the ischial tuberosity. Let me get in nice and close so that you can see the attachment. And basically, all the hamstrings here with this ischial tuberosity attachment, as well as part of adductor magnus on the most inferior aspect of that piece. But so semitendinosus there. We're going to come down. You'll see that it will course and go all the way down for its distal attachment under the medial aspect of the proximal part of the tibia, it being one of the muscles or the tendinous part of the pes anserine. Semitendinosus, its action is flexing and medially rotating the leg at the knee joint and extending the thigh at the hip joint. It's innervated tibial division of the sciatic nerve, L5, S1, S2. We'll move further to the semimembranosus. So its origin, again, ischial tuberosity. It actually will insert more laterally and anteriorly than does semitendinosus. Its insertion is the medial condyle of the tibia, so it's going to have a further posterior trajectory at the joint line than does semitendinosus. Its action is flexing and medially rotating the leg at the knee joint, and it extends the thigh at the hip joint. It's innervated L5, S1, S2. We'll look at the biceps femoris. I'm sorry, the long head, we'll look at that first. the long head of the biceps femoris. Again, origin, ischial tuberosity, so its origin is actually between the origin of semitendinosus and semimembranosus. We'll get to a dry needling protocol where we will actually needle through all three of these tendons to elicit a change in those structures. Again, long head of biceps, its insertion is into the head of the fibula. So I'll highlight that and we can see its distal attachment, again, onto the head of the fibula. It's, come back up. Its action is it flexes and laterally rotates the leg at the knee joint and extends the thigh at the hip joint. And innervation again, tibial division of the sciatic nerve L5, S1, S2. Lastly, we'll look at Adductor Magnus. So actually before that, we also want to look at the short head of the biceps femoris. And so the origin is the linea aspera and the lateral supracondylar line. And then its insertion is into the the head of the fibula as well, via the tendon. So it has an actual attachment onto the biceps femoris tendon as it travels then via that tendon down to the head of the fibula. Its innervation or its action is going to be flexing and laterally rotating the leg at the knee joint, and its innervation is the common fibular division of the sciatic nerve L5, S1, S2. Now we move on to the Adductor Magnus, and I'm going to look at it first in relation to the biceps femoris, the hamstring group. So let me zoom in here. So the Adductor Magnus, as the name implies, it covers a lot of territory. It's a large muscle. As we look at its origin, you can see it on the anterior part of the pelvis, following the inferior ramus all the way around. Move that. There we go. To the most inferior aspect of ischial tuberosity. And so a broad attachment and then its insertion. So again, the origin, the inferior pubic ramus and the ramus of the ischium and the ischial tuberosity. So its insertion is in the gluteal tuberosity, the linea aspera, the medial supracondylar line, and finally the adductor tubercle. We tend to end up needling Adductor Magnus in the bulk of the muscle belly, and depending on the protocol, we may also needle directly onto the adductor tubercle. Get all the way over there on the medial aspect of the knee.
Okay, so again, on surface anatomy, future courses, we're going to get a lot more in depth in identifying all the structures on the posterior aspect. For our purposes, for the introductory piece, we're going to keep this much more simple, and so we'll get to it right here. In looking at surface anatomy for the posterior upper leg, one area a little bit later we'll be interested in is in being able to palpate and identify ischial tuberosity. I'm not going to mark that at this point. Another thing that's incredibly important with a lot of our landmarks, especially dealing with posterior hip structures, is being able to identify the superiormost aspect of the greater trochanter. Again, at this point for this session of needling, we don't need that for our lower. But where we do need to get is in our, similar to in the elbow, we need to identify our window in the posterior lower leg. So one thing we want to do, first off, we want to identify the popliteal crease. Okay, then we want to identify a lateral and a medial margin. And quite honestly, very simply, we just want to bring the hamstrings, resist knee flexion to identify semitendinosus, semimembranosus. Go ahead and come again. Right there. And at the same time, we can identify our lateral border. Go ahead and resist. Very good there. So again, our danger zone, we want to avoid structures in the midline right here. when we're talking about dry needling into biceps femoris and into semitendinosus, membranosus, this is our identifier. We can come lateral to those lines, medial to those lines, and that gives us what we're looking for. Since we're here, we'll need it a little bit later. We're definitely going to want to know the location of the fibular head. This isn't always the best position to do this, but we're here. And so let's go ahead and mark the superiormost aspect there. Fibular head, and then dropping off into the fibular neck. There. So as a bonus on our previous surface anatomy or 3D anatomy, we were talking about semitendinosus as it comes around. So bonus question for homework that's not written down. This is just a check to see who's listening and paying attention. Name the 3 muscles or tendons that form the pes anserine. So if you'll just include that in your response to the homework, that'll be fantastic. Okay, so moving on. So posterior thigh treatment, again, this is going to be very, I'm going to say simple, very basic. We want to be able to, I've selected these areas so that we can, with one needle, catch both semitendinosus, membranosus, and then on the lateral aspect, catch both the long and the short head of biceps femoris. But we'll get to that in just a second. All right. I'm going to take a quick note here. You see all of these screens rolling by that have all this information. At the conclusion of today, before leading into the lab coming up, I've got all of these slides put together in a downloadable format that you can take, put it on your phone. Matter of fact, this is how we're going to go through our lab. You can put it on your phone, your iPad, whatever device you have, your laptop. It's just a PDF file that's searchable, that you can select each specific muscle that gives you the parameters for dry needling that. But we'll look at that in a bit. For the Adductor Magnus, patient position will be supine, needle length is 30 to 40 millimeters, and there is no backdrop. Precautions here for the great saphenous vein and the obturator nerve. With the patient in supine, the hip externally rotated and the knee at 90 degrees flexion, have them adduct into your hand and palpate for the prominent adductor longus. Ideally, have them rest their leg on your knee placed on the table. We'll grasp the bulk of the muscle posterior to the longus with the lumbrical grip at mid-thigh and needle perpendicular to the table into the bulk of the muscle. So whenever we get to the advanced course, we'll dry needle Adductor Magnus with other muscle in a little bit different form. Rare is Adductor Magnus just a problem by itself. But if you do want to isolate Adductor Magnus, we'll include the other adductors as well. This is just a nice, quick, easy way to needle into that one specific muscle. The biceps femoris, long and short head. We will come down again. We're just going to go to one thumb breadth lateral or proximal from the apex of the midline here, which is about 1 palm breadth. And then we're just going to come a little bit lateral, or 1 thumb breadth lateral to that. For the biceps femoris, long and short head, patient again is going to be in the prone position. Needle length here is 30 to 40 millimeters, and the backdrop is going to be either the femur or none at all. Precautions for the common fibular nerve and the posterior femoral cutaneous nerve. In prone position, we'll be one palm width superior to the popliteal fossa. We'll grasp the outer muscle bundle with a lumbrical grip and needle from one thumb breadth lateral to midline and a medial to lateral angulation away from the femur. Using your fingers, determine adequate depth. Caution here to avoid the popliteal neurovascular bundle, which is deep, and the posterior femoral cutaneous nerve, which is superficial. For the biceps femoris, long and short head. Patient again is going to be in the prone position. Needle length here is 30 to 40 millimeters, and the backdrop is going to be either the femur or none at all. Precautions for the common fibular nerve and the posterior femoral cutaneous nerve. In prone position, will be one palm width superior to the popliteal fossa. We'll grasp the outer muscle bundle with a lumbrical grip and needle from one thumb breadth lateral to midline and a medial to lateral angulation away from the femur. Using your fingers, determine adequate depth. Caution here to avoid the popliteal neurovascular bundle, which is deep, and the posterior femoral cutaneous nerve, which is superficial. All right, semitendinosus, membranosus. For the semitendinosus and semimembranosus, the patient will be in the prone position with a 30 to 40 millimeter needle. The backdrop here will be the femur or none. Precautions, the great saphenous vein, the posterior femoral cutaneous nerve. In prone will be one palm width superior to the popliteal fossa. We'll grasp the inner muscle bundle with a lumbrical grip and needle from one thumb breadth lateral to midline and a medial to lateral angulation away from the femur. Using your fingers, determine adequate depth. Caution here to avoid the popliteal neurovascular bundle, which is deep, and the posterior femoral cutaneous nerve, which is superficial. So I've been asked before, whenever you insert a needle, as you saw in that video, I inserted the needle fell, and then I picked it up to redirect. The initial orientation of the needle going into the skin is completely irrelevant. What is relevant is where you position it as you would start advancing that needle into the muscle. That part is critical. But getting the needle to break that surface tension of the skin, if it's a longer needle, it is going to fall, and there's nothing wrong with that. You just simply pick it up and advance it in the trajectory that you should. Okay, so on to the anterolateral thigh. Here we're going to look at sartorius, rec fem, and then vastus lateralis, intermedius, and medialis. So from here, let's move on to our three-dimensional anatomy.
Okay, 3D anatomy of the anterolateral thigh. Here we'll look at the sartorius and then the quads themselves. So let's start with sartorius. Sartorius, longest muscle in the body. Its origin is the anterior superior iliac spine. It curves from a lateral to a medial direction to then insert on the medial aspect, proximal part of the tibia, being one of the three pieces of the pes anserine. Its action is it flexes and medially rotates the leg at the knee joint. It assists in flexion, abduction, and lateral rotation of the thigh at the hip joint. It's innervated by the femoral nerve L2 and L3. Okay, so I'm going to go ahead and hide sartorius so we can have a really good look at the muscles of the quadriceps. First, let's look actually deep at the Vastus Intermedius. Its origin in the anterior and lateral surfaces of the body of the femur. Rotate there. So distal to the greater trochanter, about the line of the lesser. Its insertion is into the tibial tuberosity via the tendon of the quadriceps femoris muscle. It's not demonstrated here, but it's through the patellar, the quad tendon into the patella, and then ultimately tibial tubercle through the patellar tendon or the patellar ligament. Its action is extending the leg at the knee joint, and again innervated by femoral nerve L2 through L4. So look next at rectus femoris or rect fem. Its origin will come up nice and high. Will be on the inferior iliac spine in the supraacetabular groove of the ilium. It inserts in the tibial tuberosity via the tendon of the quadriceps femoris muscle and the patellar ligament. And its action is extends the leg at the knee joint, and it flexes the thigh at the hip joint. So crossing two joints has dual functions. Innervation femoral nerve L2, L3, L4. I will hide that. And Vastus Intermedius as well. Okay, that gives us down to Vastus Medialis and Vastus Lateralis. Let's look at Vastus Medialis first. The Vastus Medialis origin the medial part of the intertrochanteric line and medial to the spiral line in the linea aspera of the femur, extending inferiorly to the medial supracondylar line. So its origin is a fairly broad footprint, and then inserts again into the tibial tuberosity via tendon of the quadriceps femoris and the patellar ligament, and it's there at the medial border of the patella. So let's hide that, and then let's look at its innervation L2, 3, 4 femoral nerve, Vastus Lateralis. So here, that hand is in the way. Okay, so its origin, the intertrochanteric line, the greater trochanter, the gluteal tuberosity, and the lateral lip of the linea aspera of the femur. So again, fairly large footprint for its origin, and it inserts again at the lateral aspect of the patella via the quadriceps tendon, and tibial tuberosity via the patellar ligament. Again, its innervation femoral nerve L2, L3, L4. One thing of note, it's not listed here, but let's try to put in the iliotibial tract. On the right. Okay, let's come back to it. So whenever palpating the IT band, you can see it actually comes down and envelops the majority of that vastus lateralis. However, the most prominent part that we can palpate will fall right in line right here. So a decent amount of vastus lateralis sits posterior to the IT band that we can palpate.
Okay, so surface anatomy for the anterolateral hip, certain things that we absolutely need to know. One's going to be the greater trochanter. There is a lot of other stuff in here that we'll need eventually. Right now, the biggest things we want to be able to identify the ASIS and the pelvic tubercle. And the reason for that is we need to be able to identify, especially in the advanced course, whenever we get to the iliacus and the psoas, as it's coming down underneath or beneath the inguinal ligament, we need to be able to identify the femoral artery, and so that we can know the orientation of our needling. Yes, we do needle quite a bit in here. There's a lot of structures that need to be needled, especially for the hip OA. So being able to identify that femoral artery is critical. You have to be patient. You have to just get a good feel for it. For some people, it's harder to find. For some people, it's just very prominent and evident. So for the identifying the muscles themselves, we'll just move down to Okay, yeah. So I'm just saying the biggest thing is the ASIS. I didn't even go into a big production on that. So we absolutely will when we get to the advanced coursework. So as far as treatment, there are, what I'm going to give are 1, 2, 3, 4, 5 locations. Now, one thing that's going to be interesting is I want a safe placement to distinguish the rec fem versus the vastus intermedius. And so for rec fem, for this introductory course, we're going to needle it up high. We're going to use a specific angulation to make sure that we get into that tendinous structure of, and I say tendinous, it's a myotendinous junction right here, but we get a good response out of that muscle in that area. Truth be told, a little bit later, as we're doing some more advanced needling, we can drop through the bulk of the belly of the muscle itself and get through that. Also get through vastus intermedius sitting posterior to it, and get both muscles at the same time. But I do want to be able to differentiate one from the other if we're looking at it as a more of a diagnostic tool. So let's just jump straight to it. Let me come down to our video. For the sartorius, position is going to be supine. Needle length is going to be 30 millimeters, and there's no backdrop. Precautions here for the ilioinguinal nerve, the anterior cutaneous branch of the iliohypogastric nerve, the lateral femoral cutaneous nerve, the superficial circumflex iliac artery, and vein. And supine, we're going to locate the ASIS, and with the knee at 90 degrees and hip externally rotated, we're going to have the patient lift the heel toward the buttocks. To needle the muscle, follow it 2 to 3 fingerets caudally. Caution for the neurovascular bundle and the femoral triangle. Sartorius is the lateral border. And insert the needle into the muscle with a medial to lateral orientation. The muscle can be isolated with a pincer grip or by bracketing. So a little short story. I had an athlete, he's a collegiate basketball player, who had finally came to me. Matter of fact, he was the son of an orthopedic surgeon. He was having some pain up around the hip. They had even gone through and done some injections in the area, had gone and had started some pain management injections. And as I palpated and tried to use some fairly simple basic techniques to find out what was going on with this kid, simply identified it as a sartorius problem. And he had been out of school for 3 or 4 weeks, not been playing. About 2 sessions of needling sartorius, that pain was gone, function returned, and he was back to play. So sartorius often overlooked, but given the location up there, a good assessment, a good palpation assessment can give you a lot of good information on what you're looking for. Okay, on to rec fem. Again, this is going to be this location up high. We're going to use the greater apex of the greater trochanter and align with the ASIS to come down at its meeting of those 2 lines, and that's going to be our needle location A to P. For rectus femoris, the position is supine. Needle length here is going to be 30 to 40 millimeters. The backdrop is either going to be the femur or none at all. Precautions here are for the lateral circumflex femoral artery and vein, the lateral femoral cutaneous nerve, the superficial circumflex iliac artery and vein, and the muscular branches of the femoral nerve. To needle the rectus femoris, we'll palpate the ASIS and the apex of the greater trochanter. We'll insert the needle where the lines of those points intersect between the sartorius and the TFL and advance in an anterior to posterior angulation. There will be no backdrop unless needling deeper to the vastus intermedius. So important here, we're looking more for the apex, not necessarily the superior-most aspect, but the lateral apex, the lateral-most part, and then it's just going to be anterior to posterior, right there. For Vastus Lateralis, we're going to simply use the IT band as a location to determine our needle placement, and we will be at mid-thigh for this, and we get the bulk of that muscle. It's going to simply be lateral to medial with the femur as a backdrop. For the vastus lateralis, the patient will be in the supine position and needle length will be 30 to 40 millimeters. The backdrop here will be the femur or none. The precautions are for the lateral femoral cutaneous nerve, the descending branch of the lateral circumflex femoral artery. This can be treated in a direct or a threading approach. Both methods utilize the IT band as a reference. In the direct approach at mid-thigh, locate the anterior border of the IT band by resisting abduction. We'll needle from lateral to medial with a 10 to 20 degree posterior angulation with the femur as a backdrop. In the threading approach, we'll locate the IT band at mid-thigh. We'll grasp the muscle belly of the lateralis and advance the needle in an anterior to posterior direction towards the table about 1 finger breadth medial to the medial border of the IT band, using your fingers in the posterior side to assist in determining the appropriate depth. So a direct approach, looking for the femur as a backdrop. And then here we'll look at the threading approach. Either way is satisfactory. Maybe patient position would be the indicator of which one to do. Either one gives us a really good response. We will get through a little bit more bulk of that muscle through this threading approach. Okay, then vastus intermedius. Again, we're going to take a midpoint between the ASIS and the superior aspect of the patella, and in a midline along that line, we're advance the needle in an anterior to posterior direction with the femur as a backdrop. For vastus intermedius, patient is in the supine position and we're using a 30 to 40 millimeter needle. The backdrop here will be the femur. Precautions here also the lateral circumflex femoral artery and vein, the lateral femoral cutaneous nerve, the superficial circumflex iliac artery and vein, and the muscular branches of the femoral nerve. Needle this muscle mid-thigh, passing through the rectus femoris. Orientation is aligned from the ASIS to the patella. We'll advance the needle in an anterior to posterior angulation using the femur as a backdrop. And then finally, the vastus medialis. Again, so what we'll do is we'll use the patella as our orientation. We're going to come up about 3 finger breadths and then medial 2 finger breadths, and we're going to insert the needle and angle it just toward the femur, using the femur as the backdrop. For the vastus medialis, the patient is in the supine position. Needle length here will be 30 to 40 millimeters. The backdrop is going to be the femur. Precautions: femoral artery and vein, the saphenous nerve, the muscular branch of the femoral nerve. The needling location is 3 finger breadths superior to the medial superior pole of the patella, and then 2 finger breadths medial. We'll insert the needle in an angle towards the femur, using it as a backdrop. Okay, moving on down to the lower leg. We'll look at 3 different sections here. Then we'll get to the tendons, tendons and ligaments, and then we'll be done. So in the lower leg, let's start with the anterolateral. Here we'll look at the tibialis anterior, extensor digitorum longus, extensor hallucis longus, and then Peroneus Tertius, longus, and brevis. So let's move on into our 3-dimensional anatomy.
And then 3D anatomy of the anterolateral lower leg. Here we'll look at Tib Anterior, the extensor digitorum longus, the extensor hallucis longus, sitting right there, and then the peroneal or the fibularis longus, brevis, and tertius muscles. So first let's talk about Tib Anterior. Let's fade the others. So, oops. Try that again. Fade the others. Good. Not sure what's happening there. Try it one more time. Fade the others. All right. Okay, so tibialis anterior, it has as its origin the lateral condyle of the tibia, the proximal half, the lateral surface of the tibia, and the adjacent interosseous membrane of the leg. It inserts into the inferomedial aspect of the medial cuneiform, and get further down, right there, and the base of the first metatarsal. Its action: it dorsiflexes the foot at the ankle joint, and it inverts the foot at the subtalar and the transverse tarsal joints. It's innervated by the deep fibular nerve, L4, L5. Okay, we'll come up, and actually I'm going to hide that from view so that we can now look at extensor digitorum longus. So extensor digitorum longus, the origin is the lateral condyle of the tibia and the proximal 3/4 of the fibula and the adjacent interosseous membrane of the leg. It inserts in the dorsal aspects of the bases of both the middle and distal phalanges of the 2nd, 3rd, 4th, and 5th little toes. Let's see that out further distally. So interestingly, we'll get to this when we dry needle. We're going to use the fibula as our backdrop here. So we'll catch tib anterior right about here. Extensor digitorum longus will catch right about this area, just dropping down into that muscle right anterior to the fibula. Okay, and then let me go ahead and hide that. Okay, and now the extensor hallucis longus. So here, origin will be the medial surface of the fibula. So whereas extensor digitorum was just anterior, this is going to sit a little bit medial, and it's in the adjacent interosseous membrane of the leg. It inserts in the dorsal aspect of the base of the distal phalanx of the big toe. It extends the great toe, and it dorsiflexes the foot at the ankle joint to a lesser degree. Its innervation is the deep fibular nerve with the root of L5. Okay, and I'm going to leave that one in place. Let's move up to Peroneus Longus or Fibularis Longus. Its origin is going to be the head of the fibula, of the lateral surface of the fibula and the adjacent intermuscular septa. It inserts into the plantar surface of the medial cuneiform at the base of the first metatarsal. So as we see that coming down and around, there is its insertion. So very circuitous route for Peroneus Longus. All right, and it's also innervated by the superficial fibular nerve L5S1. Okay, I'll hide that so that we can see Peroneus Brevis. Okay, so Peroneus Brevis, its origin is the lateral surface of the fibula and the adjacent intermuscular septa. It inserts in the tuberosity of the fifth metatarsal bone, and so whereas Peroneus Longus follows a very similar course posterior to the lateral malleolus, their final insertion is on opposite sides of the foot, so they play a big role in an inversion eversion there. The action, it everts the foot at the subtalar and transverse tarsal joints, and it assists in plantar flexion of the foot at the ankle joint. It's also innervated by the superficial fibular nerve L5S1. So finally we'll hide that, and then we'll get to Peroneus Tertius. Here our origin is a medial surface of the fibula. The adjacent interosseous membrane of the leg inserts into the dorsal aspect of the base and body of the fifth metatarsal bone. So Peroneus Longus took a posterior route to insert here, and Tertius inserts more dorsally. Its action, it dorsiflexes the foot at the ankle joint. It assists in eversion of the foot at the subtalar and the transverse tarsal joints, and its innervation is the deep fibular nerve L5S1.
All right, so our surface anatomy, we'll take a look at that. For surface anatomy of the lower leg, especially the anterior lateral, anterolateral aspect, we want to first identify the patellar border, or the apex, the inferior pole. From here, we can have our patient extend the knee briefly to help identify the medial lateral, go ahead and relax, borders of the patellar ligament. Again, I marked it on the other leg, but we next want to look at the fibular head. We use the fibular head in a lot of our, as an important landmark for a lot of our needling structures. Also important to identify the tibial crest, because it's going to be used on our needling here as well. Since we're here, we also want to be able to identify our joint line, because that will be useful for identifying our lateral collateral ligament. We use it medially as we come along to identify our medial collateral. I'm not going to draw it, but we also want to be able to identify our lateral malleolus and our medial malleolus. So a lot more surface anatomy that we'll get to whenever we get to the advanced portion of the knee and lower limb. For what we're going to do in this session, these structures give us everything that we need. Okay, so the anterolateral lower leg treatment. So 6 different structures. We'll start with the tib anterior. So whether it's shin splints, whether it's drop foot, whether it's just some other sort of pain, tib anterior is probably one of the more common ones to needle on the anterolateral aspect. So let's move straight into that. So here, needling point is going to be 1 to 2 finger breadths distal to the tibial tuberosity, and then 2 to 3 finger breadths lateral from the tibial crest. And we're going to just use that lateral tibial surface as the backdrop. For the tibialis anterior, the patient will be in the supine position. Needle length here will be about 30 millimeters with the backdrop onto the tibia. Precautions for the anterior lateral genicular artery, the anterior tibial recurrent artery, the circumflex fibular artery and vein, the anterior tibial artery, the anterior tibial veins, and the deep fibular nerve. The needling point will be 2 to 3 finger breadths distal to the tibial tuberosity and 1 to 2 finger breadths lateral from the tibial crest. We'll needle from anterolateral to posteromedial with the lateral tibial surface being the bony backdrop. Caution regarding the deep fibular nerve, anterior tibial artery and veins at the interosseous membrane. If the needle goes posterior to the tibia, there is a risk of contact with those structures. So in just a moment, we'll look at Extensor Digitorum Longus. There will be a very similar needle placement. The biggest difference is going to be the needle orientation and angulation. Whereas this is lateral to medial, anterior to posterior, that one is going to be more anterior to posterior down to the fibula as the backdrop. For the extensor digitorum longus, patient again is in the supine position. Needle length will be about 30 millimeters. There will be no backdrop. Precautions for the anterior lateral genicular artery, the anterior tibial recurrent artery, the circumflex fibular artery and vein, the anterior tibial artery and the anterior tibial veins, and the deep fibular nerve, the lateral sural cutaneous nerve. Here we're going to palpate the anterior surface of the fibular head. We're going to move 3 finger breadths distal and insert the needle into anterior posterior angulation. The muscle is superficial, 15 to 20 millimeters of depth, and we might contact the fibula as a backdrop. And more often than not, I do choose to use the fibula as the backdrop just to guarantee that I'm in the bulk of that muscle that I'm trying to target. So we'll move further distally down for extensor hallucis longus. Here will be 4 to 5 finger breadths superior from the apex of the lateral malleolus and will be 1 finger breadth lateral from the tibial crest. We'll have a lateral to posteromedial trajectory with the tibia as a backdrop. The extensor hallucis longus position, supine, preferably on a bolster. Needle length is about 30 millimeters and the backdrop is down to the tibia. Precautions here, the anterior tibial artery and veins, the deep fibular nerve. Extensor hallucis longus can be best palpated as the patient extends the great toe. Needling location will be 4 to 5 finger breadths superior from the apex of the lateral malleolus, and then 1 finger breadth lateral from the tibial crest, and a lateral to posteromedial trajectory with the tibia as a backdrop. Caution of the anterior tibial artery. And then Peroneus Tertius is going to be fairly similar in its needle placement, maybe just a little bit inferior. It's going to be located 4 finger breadths superior to the lateral malleolus, anterior to the lateral fibular border. The needle angulation here is lateral to medial with no backdrop. I say lateral to medial, away from midline. So technically it's going to be medial to lateral. For Peroneus Tertius, position again supine on a bolster. Needle length is 30 millimeters with no backdrop. Precautions here: superficial fibular nerve and the perforating branch of the fibular artery. Needle location is located 4 finger breadths superior to the lateral malleolus, anterior to the lateral fibular border. Needle angulation is lateral to medial with no backdrop. So I stand corrected on my previous comment. It is lateral to medial, as that muscle moves more from the fibula towards its insertion on the 5th metatarsal. So as I said, it originally is correct. Stand corrected. Okay, now to the other peroneal muscles. The Peroneus Longus, it sits in the proximal 2/3 of the fibula, and we will be 4 finger breadths distal from the fibular head. We're going to bracket the muscle belly, and we'll needle lateral to medial using the fibula as a backdrop. For the Peroneus Longus, the patient will be in the supine position. Needle length will be about 30 millimeters. The backdrop here is going to be the fibula. Precautions for the anterior lateral genicular artery, the anterior tibial recurrent artery, the circumflex fibular artery and vein, the anterior tibial artery, the anterior tibial veins, the deep and common fibular nerve, and the lateral sural cutaneous nerve. The muscle sits in the proximal 2/3 of the fibula. So 4 finger breadths distal from the fibular head will bracket the muscle belly and needle lateral to medial using the fibula as a backdrop. And then Peroneus Brevis. Here, the muscle sits on the lower third of the distal fibula. Needle angulation is perpendicular to the fibula, 3 finger breadths superior from the Peroneus Tertius needle point, which is partly why I needle Peroneus Tertius first. Which is 4 finger breadths superior from the apex of the medial malleolus, from lateral to medial with the fibula as the backdrop. For Peroneus Brevis, again, supine, knee on a bolster. Needle length is about 30 millimeters. Our backdrop here is the fibula. Precautions: the lateral sural cutaneous nerve. This muscle sits on the lower third of the distal fibula, where the needle angulation is perpendicular to the fibula, 3 finger breadths superior from the Peroneus Tertius needle point, which is 4 finger breadths superior from the apex of the medial malleolus. And we're going to go from lateral to medial with the fibula as a backdrop. So in the event that you're needling Peroneus Brevis and don't feel a need to mark or needle Peroneus Tertius, that method would be 7 finger breadths, or a palm breadth plus just a little bit more to ensure that you're into that distal third of the fibula to get into Peroneus Brevis. Okay, so now superficial posterior, our gastroc, our soleus, and our plantaris. So we'll move on down, look at our 3D anatomy here.
For our superficial posterior lower leg muscles, we'll look at the plantaris, the gastrocnemius, and the soleus. So let's actually start with gastrocnemius. both a lateral and a medial head. The lateral head, the origin is the lateral condyle and lateral supracondylar line of the femur. So crosses that joint line for its origin, and then inserts into the posterior surface of the calcaneus via the calcaneal tendon. Its action is plantar flexion of the foot of the ankle joint, and because it crosses the knee joint, it also flexes the leg at the knee joint. It's innervated by the tibial nerve S1 and S2. On the medial head, again here, its origin, get that back, is the medial condyle and the popliteal surface of the femur. So you'll see it is not far from the adductor tubercle where Adductor Magnus inserts. Its insertion, again, posterior surface of the calcaneus via the calcaneal tendon, and also plantar flexion of the foot and flexion of the leg at the knee joint. Innervation, again, tibial nerve S1, S2. So I'm going to hide gastrocnemius. Okay, then we'll look at, let's look at Plantaris. Plantaris, its origin is the lateral supracondylar line of the femur, so it's going to sit just medial to the lateral head of the gastroc. It inserts in the posterior surface of the calcaneus, so long tendon that runs just anterior. Let's see if we can still see that there. So the calcaneal tendon. Between that and then the surface, or posterior to the surface of soleus. Its action assists in plantar flexion. It's a weak plantar flexor of the foot at the ankle joint and assists in flexion of the leg at the knee joint. Innervation here, tibial nerve S1, S2. How relevant is Plantaris? It's hard to say. I always like to think that the Plantaris is the cause of a lot of posterior knee pain. Odds are it's probably not involved that much, given how small it is, but it is there and it can be needled, and we will cover that in our introductory dry needling session. So we'll hide that and get now to soleus. Soleus, the origin is going to be the head of the fibula, and then the posterior surface of the fibula and the soleal line and medial border of the tibia. So two different bone origins for soleus. Big, broad muscle responsible for more power for plantar flexion. It inserts the posterior surface of the calcaneus via, again the calcaneal tendon. And actually, let me move that. Okay, so its fibers insert much further distally into that tendon. And it's actually, again, plantar flexion of the foot at the ankle joint, and again, tibial nerve innervation S1, S2.
So some palpation. Okay, so palpation, trying to identify that. We've got our fibular head and the similar posterior knee landmarks. We don't really have to have a whole lot more than that for these, the gastroc, the soleus, and Plantaris. So I'm going to skip playing that and move on to the needling. So these are really fairly simple and basic needle locations. We'll get into each of those. Plantaris. So Plantaris is going to sit inside that danger zone we talked about. And we will needle it. Our important thing is we want to stay away from midline. So we'll find we're going to be one thumb breadth away from midline, and then we're going to still needle slightly medial, slightly lateral, away from midline. Gastroc and Soleus, as you'll see, really easy, really powerful needling with those two. So gastroc, we will, and it can be treated in both prone or supine. Here, we're going to do it in prone. Will be 4 finger breadths distal from the popliteal crease. We're going to grasp the medial, which is more common than the lateral. We're going to do both. Head of the gastroc, and we're going to needle with an angulation from posteromedial to anterolateral, so away from midline, so that we avoid the remaining neurovascular structures as they're coming down into the calf. For the gastrocnemius, the patient will be in the prone position. Needle length here will be 30 to 40 millimeters, and there's no backdrop. Precautions for the popliteal artery and vein, the small saphenous vein, the tibial nerve, medial lateral cerulocutaneous nerve, the posterior femoral cutaneous nerve. This can be treated in either the prone or the supine position. In either position, 4 finger breadths distal from the popliteal crease will grasp the medial, which is more common than lateral, gastrocnemius, and it will needle with an angulation from posteromedial to anterolateral away from midline to avoid the midline neurovascular structures. And so here we're just demonstrating the medial aspect. Easily could also go ahead and needle the lateral as well. Probably not a bad idea to do that. As far as a protocol, I would probably limit myself to the medial simply because we tend to see more dysfunction there on that medial piece. For the soleus, again, we're going to use a midpoint between the popliteal crease and the calcaneus. And we will come and needle both lateral and medial to that as well. For the soleus, patient again is in the prone position. Needle length will be 30 millimeters and there is no backdrop. Precautions here, the posterior tibial veins and arteries, the tibial nerve, medial and lateral cerulocutaneous nerve, and the saphenous nerve. This can be treated in prone or supine. In either position, at the midpoint between the popliteal crease and the malleoli, grasp the medial or the lateral aspect of the muscle belly and needle with an angulation from posteromedial to anterolateral away from the midline to avoid the midline neurovascular structures. So right in midline, midpoint between the insertion and the origin, you'll also note a little bit later, we'll look at it, that is also the myotendinous junction of the gastroc into the tendon of the calcaneus. So for the soleus itself, you're going to be needling truly through that myotendinous junction as you're kneeling into the soleus. Nothing wrong with that, perfectly fine. Definitely medial, probably our first option, then lateral if symptoms persist. And then lastly, plantaris. Here it sits medial to the lateral head of the gastroc. So we're going to, needle placement is going to be 1 thumb breadth lateral from midline in the popliteal crease. And then we'll have a little medial to lateral angulation. Backdrop will be down because it's such a small muscle. We'll have to use the femur as a backdrop to ensure that we actually make contact with that muscle. For plantaris, position here is going to be prone. Needle length is 30 millimeters and the backdrop is going to be down to the femur. Precautions, the femoral and popliteal artery, the popliteal and small saphenous vein, the tibial and the common fibular nerve. Plantaris sits medial to the lateral head of the gastrocnemius. Caution must be taken in the popliteal fossa of the neurovascular structures. Needle placement should be 1 thumb breadth lateral from midline in the popliteal crease at the level of the superior pole of the patella anteriorly with a medial to lateral angulation. So here we have the musculature or the surface anatomy that we did for the posterior knee for semitendinosus, membranosus, and biceps femoris. We're going to use that same angle. We're going to draw a midline, and then we're going to use the superior pole of the patella to give us our location. One thumb breadth lateral. That ensures we miss any of the neurovascular bundle. And then finally, the deep posterior muscles here, the popliteus, flexor digitorum longus, flexor hallucis longus, and tibialis posterior. I like needling these muscles specifically for my first line of defense for plantar fascia. All of these muscles have ligaments that travel medially and then insert on the base of the foot. And so a very good first line, again, for plantar fascia for needling these. Neuromuscular dysfunction, we'll cover this later, but the neuromuscular dysfunction in these muscles, because there's a low load pull on the tendons on the bottom, tend to be where we see most of the cause of that plantar fascial symptoms. And so once we get to the advanced foot and do the needling there, which I hope to have a model for that, but I digress. Much kinder to needle and deal with the foot up in the posterior calf than into the foot itself. So first will be popliteus. And we've got some 3D anatomy. Let's go get that.
And for the muscles of the deep posterior lower leg, here we'll look at flexor digitorum longus, flexor hallucis longus, popliteus, and the tib posterior. So let's start with popliteus. Let me get a nice zoom in here. So its origin is on the groove for the popliteus muscle on the tibia. It starts at a medial location, and then moves superiorly and laterally to come and insert on the posterior surface of. So let me do that backwards. The origin is the groove for the popliteus muscle laterally, and then it takes an inferior and medial course to insert in the posterior surface of the tibia, superior to the soleal line. So always consider origin is the broader piece, but technically origin, insertion. Its action, it immediately rotates the leg at the knee joint. It unlocks the knee joint at the beginning of knee flexion. It's innervated by the tibial nerve, L4, L5, and S1. Let's move to flexor digitorum longus. All right, let me pull it out. So another muscle with a circuitous route. The muscles of the deep posterior lower leg, as far as a treatment approach for why we're treating these, definitely some of this deep posterior calf pain, but as we'll see momentarily, these muscles all terminate on the plantar surface of the foot. So we use these extensively dealing with plantar fasciitis, any of the plantar surface of the foot. Always a good option. Treat these muscles first. See if we can reduce some muscle tension, some tightness in those tendons as they attach on the plantar surface. But flexor digitorum longus, the origin is the posterior surface of the tibia, inferior to the soleal line. It inserts into the plantar aspects of the bases of the distal phalanges of the second, third, fourth, and little toes. Its action is flexing that second through fifth toe and plantar flexing the foot at the ankle joint. Innervation here is tibial nerve L5, S1, S2. We move laterally for the flexor hallucis longus. Here our origin is going to be the distal 2/3 of the posterior surface of the fibula and the adjacent interosseous membrane of the leg. It inserts in the plantar aspect of the base of the distal phalanx of the great toe. So it's covered with a lot of connective tissue there There's a tenosynovium, and then just more tissue. Its action, it flexes the great toe and plantar flexes the foot at the ankle joint. Again, innervation is via the tibial nerve L5, S1, S2. And then finally, let me come in. I'm going to hide those two to give us tib posterior. Here the origin is the posterior surface of the tibia, inferior to the soleal line, its posterior surface of the fibula, and the adjacent interosseous membrane of the leg. So again, another of the muscles with multiple bony origin. Its insertion is, let me get all the way down here. Okay, so our insertion of tib posterior is the tuberosity of the navicular bone, the plantar aspects of the medial, intermediate, and lateral cuneiform bones, and the plantar aspects of the bases of the second to the fourth metatarsal bones. Its action is inverting the foot at the subtalar and transverse tarsal joints, and it plantar flexes the foot at the ankle joint. Its innervation is the tibial nerve L4, L5.
So for treatment, Popliteal, well, I'll get straight to the treatment video and let it do the talking. For the Popliteal, the patient position is going to be prone. Needle length will be 30 millimeters with the backdrop down to the tibia. Precautions: the popliteal and posterior tibial artery and veins, the right tibial nerve, and the great saphenous vein. The Popliteal inserts on the posterior medial aspect of the proximal tibia above the soleus. It extends posteriorly to the lateral femoral condyle. Grasp the medial proximal gastroc and palpate the lateral tibial border. Needle location is at the opposite level of the fibular neck, 1 thumb breadth lateral to the midline of the heads of the gastrocnemius. Needle perpendicular, P to A, to the tibia to avoid medial migration to avoid the neurovascular bundle. So Popliteal is similar to Plantaris. Superiorly, Popliteal is a technical dry needle that has to be very close. 1, to avoid the neurovascular bundle, but 2, because it's a smaller muscle, to make sure that we actually make contact with what we're trying to actually dry needle. Flexor Digitorum longus. For Flexor Digitorum longus, position here is going to be a prone position. Needle length is 30 millimeters, and the backdrop is the posterolateral aspect of the tibia. Precautions: the posterior tibial veins and artery. What we're going to do is compress the medial gastrocnemius at mid-calf and needle from posterior to anterior, from lateral to medial, with the lateral aspect of the tibia as a backdrop. We'll needle through the soleus before reaching FDL. And then for flexor hallucis longus. For flexor hallucis longus, position again is prone with a 40 millimeter needle. Backdrop will be down to the fibula. Precautions: the fibular artery and veins and the sural nerve. We're going to compress the lateral gastroc at the mid-calf and going to needle from posterior to anterior with the fibula as a backdrop. And then for tib posterior. For tibialis posterior, again, prone position, needle length about 30 to 40 millimeters. The backdrop down to the fibula. Precautions here, the fibular artery, the posterior tibial artery, posterior tibial veins, fibular veins, and the tibial nerve. To take a lateral approach, there will be 3 finger breadths distal from the fibular head. We're going to insert a needle and advance with a slight posterolateral to anteromedial angulation of about 10 degrees posterior to the fibula with no backdrop. From a posterior approach, we're going to compress the lateral gastroc belly 3 finger breadths distal to the fibular head. Needle angulation is posterior to anterior towards the fibula as a backdrop. Okay, onto the tendons and ligaments. We're almost there. We're just going to look at 4 here. Some 3D anatomy, just really quick.
And finally, a 3D look at 4 of the tendons and ligaments in the lower leg. First would be the patellar ligament, the patellar tendon, patellar ligament. Technically, it's a ligament since it connects bone to bone. However, it's frequently referred to patellar tendon. Anyway, I digress. It's attached to both the tibial tubercle and the inferior aspect, inferior pole, or the apex, technically, of the patella. Moving further laterally, the fibular or lateral collateral ligament. It's a broad band located along the lateral aspect of the knee. It originates from the lateral epicondyle of the femur and then it passes obliquely to join the tendon of the biceps femoris muscle distally to form a conjoint tendon. The conjoint tendon inserts into the head of the fibula. Unlike the tibial or the medial collateral ligament, fibular collateral ligament is not fused to the lateral meniscus or the articular capsule of the knee. Hence, it is more flexible than the tibial collateral ligament and less susceptible to injury. And so let's go medially and let's look at the medial collateral or tibial collateral ligament. It's one of 4 major ligaments of the knee joint. It's a broad band on the inner knee and attaches superiorly to the medial epicondyle of the femur, and inferiorly it attaches first to the anterior band of semimembranosus muscle and then continues inferiorly to attach the medial surface of the tibia deep to the pes and serine. Unlike the fibular collateral ligament, the tibial or medial collateral ligament is fused to the medial meniscus and the articular capsule of the knee joints. Hence, it is less flexible than the fibular collateral ligament and it's more susceptible to injury. And then lastly, let's drop and let's look at the Achilles tendon or the tendocalcaneus. So here it is the long tendon that attaches the muscle bellies of the triceps surae muscles to the posterior surface of the calcaneus. Proximal end of the tendon begins in the middle of the leg, where the fibers of the triceps surae begin to converge and form this single tendon. Proximal to its insertion site, the calcaneal tendon spirals, which results in the gastrocnemius fibers inserting laterally on the calcaneus and the soleus fibers inserting medially.
Okay, so for lateral collateral, the proximal attachment, I've done that. Needle length is going to be 1.5 up to 3 centimeters. 3 centimeters is not going to be needed as far as total penetrating depth. 1.5 to 2 centimeter needle will be more than enough. No backdrop if you land on backdrop either superiorly or inferiorly. There's nothing wrong with that. As we go a little bit further, you'll see that we do frequently needle into that soft tissue in the joint line for specific reasons. The fibular or lateral collateral ligament position treatment is side lying with the treatment side up. Needle length is 1.5 to 3 centimeters. There's no backdrop. Precautions here: the inferior lateral genicular artery. For the procedure, we'll palpate and determine the lateral joint line and the lateral collateral ligament. Needle location will be at the midline of the lateral collateral ligament, lateral to medial without a backdrop. So just a quick evaluation to make sure I'm on the lateral collateral ligament, and then it's just simply going to be lateral to medial to that ligament. Okay, medial collateral, very, very similar. The medial or tibial collateral ligament position is supine with the knee on the bolster. Needle length is 1.5 to 3 centimeters. The backdrop will be the joint capsule and medial meniscus. Precautions here: the saphenous nerve, the articular branches of the tibial nerve, the inferior medial genicular artery and vein, and the superior medial genicular vein. For the procedure, we'll palpate the medial epicondyle of the femur. We're going to slide distally across the medial joint line to locate the broad fibers of the medial collateral ligament. The needle location will be in the joint line, medial to lateral angulation, perpendicular to the skin surface, with a backdrop of the joint capsule and medial meniscus as a backdrop. So similar, want to go down the joint line, find where the medial collateral bumps into your fingers, and then just a medial to lateral trajectory into that ligament. Patellar ligament, quite simply, we're going to find the inferior pole, we're going to find the tibial tubercle midpoint, and we're just going to drop 1.5 up to 3 centimeters of a needle length. It won't require that whole length, and there's no backdrop. The patellar ligament position is going to be supine with a bolster underneath the knee. Needle length is 1.5 to 3 centimeters with no backdrop. Precautions: the patellar anastomosis, the anterior tibial recurrent artery, and the articular branch of the tibial nerve. The procedure will palpate for the midpoint between the inferior pole of the patella and the tibial tuberosity, the attachment sites of the patellar ligament. The needle location is at the midpoint and in an anterior to posterior angulation. So for patellar tendonitis, needling that structure is quite effective at reducing that anterior knee pain. Very frequently, it's because there is a significant amount of neuromuscular tension in the quads, the rec fem specifically, as it comes down to pull. So protocol-based, I would needle that patellar tendon, but I would also come up, make sure that I'm needling rec fem as well, to make sure that we're not just taking care of symptoms, but decreasing the load on that structure. And then finally, the Achilles tendon. For the Achilles tendon position for the patient for treatment, it's going to be prone. Needle length is 1.5 to 3 centimeters. The backdrop is either the calcaneus or none. Precautions here: the calcaneal branches of the posterior tibial and the fibular artery,
the medial surocutaneous nerve, the surocommunicating branch of the fibular nerve. For the procedure, we're going to palpate for the junction of the Achilles tendon and the gastrocnemius. Here, needle location will be at this junction in a posterior to anterior angulation with 2 needles, 1.5 centimeters, one finger breadth medial and one finger breadth lateral to midline. Distally, we'll palpate for the attachment of the Achilles tendon to the calcaneus. Needle location will be at this junction with the calcaneus as a backdrop using a 1.5 centimeter needle pecking on the periosteum in a posterior to anterior angulation.
Now, I don't always dry needle with a big black stick like that, but this is my wife as my subject, and I think she had had enough needling for the day. So for demonstration purposes, actually, you can barely see calcaneus there, but so that is the fourth of the tendons and ligaments that we're going to do. And so I'm going to move on to the post-lecture assignment. We have now gotten through all of the introductory material. We've got a lab coming up before we do that, your post-lecture assignment. Your patient has shoulder impingement. Pain is 4 out of 10 with flexion and abduction. Strength is 4 out of 5. There's tenderness in the posterior and the lateral shoulder. I want you to name 6 muscles that may be involved in order of likely importance. There's an answer that I want to see, but there's actually no right or wrong answer here. So that is that part of the post-lecture assignment. So up next is going to be our lab. In this lab, there are 53 plus or minus different needle sticks. As you see on this screen, on our student portal, I've taken all of these the instructions for how to dry needle, and I've placed all 53 in there. You'll be able to go to the student portal and you can download that. I have mine on my cell phone. I can scroll through it. I can search it so that I get down to each one that I want to reference. In the past, I've used big, thick manuals. I think I'm going to move away from that so that this is much more portable. You can carry it. You get the same information right there. So for our lab coming up, this is going to be the bulk of what we're going to use for that lab. In addition, so I encourage you go find that, download that. If you have problems getting to that, let us know and we can direct you to it. In addition, we're going to go through surface anatomy. So as you can tell, critical to especially some of these technically challenging dry needling sessions, we have to be very specific to our surface anatomy. So, excuse me, on the first step in our lab, what we're going to do is identify these specific both landmarks and muscle groups. So I encourage you between now and lab to review the information in the lectures and be prepared on very first thing to draw these on your fellow lab partners, because that's very critical in moving forward to do that as you get clinical with applying dry needling. When I first started dry needling, did I draw some of these structures? Absolutely, I did. Till I got comfortable with my palpation skills, my three-dimensional awareness of where all the structures were. Do I draw them now? Well, absolutely not. But it is a good tool to get in the practice of making sure that you identify your structures rather than just simply dropping a needle somewhere. So that'll be the first step on the morning of that lab. If you have any questions, feel free to contact me there. You've made it. You've gotten through the first 4 lectures. That's the good news. The better news is that after we complete this next lab, you'll be able to take this to clinic and start using it. and then there are only 12 more lectures. The remainder of the lectures gets much more in depth into a lot more structures. But like I like to say, probably 60 to 75% of what we treat in clinic comes from this material right here. It's the remainder of the advanced that gives you the people that just don't respond to the basic dry needling piece. So I will see each of you at the lab that you've signed up for. And then after that, I will see you for lecture number 5, which is the advanced cervical.